Start. Welcome to AETCM. Today we have Dr. Anu sir, our consultant ophthalmologist, to chair our discussion. So today we have a case on 22-year-old male who came to our ER with complaints of both eye pain, which occurred following a accidental fall of chemical on his eyes. Sir, shall we begin, sir?
Yeah.
So on initial examination, patient was conscious oriented, and in the primary survey, the airway, breathing, circulation part was very normal, and in disability wise, GCS was full and pupil was 3 mm bilaterally reactive, and exposure was done also, and in secondary survey, on looking forward, the patient was a 22-year-old male who had no known comorbidities, working in a detergent making industry, give the history of accidental fall of caustic soda NaOH in both eyes while handling it. It was followed by pain over both eyes, sir. And he reached in hospital within 1 hour of the falling of the chemical. And there is no other history of blurring of vision, loss of vision, or discharge from the eyes. It was the main complaint. On reaching our hospital itself, our initial management was pain relieving followed by eye wash. We gave a topical anesthetic agent for the pain relieving. And
was there any damage? The surrounding skin, no damage was there?
On examination, there was no surrounding skin damage was noted. Just a little. They already done water irrigation from there at the site of injury, and they came following it. And on examination, outside local examination part, face and head appears normal, sir. No injuries were noted, and in eyes, conjunctival chemosis were noted. Right and left eye conjunctival chemosis were noted. In vision was 6/6 both eyes, and extraocular muscle movements were full in both eyes. Eyelid appeared normal. Mild edema was noted on the right eye, sir.
Okay.
And in cornea, size and shape were normal. In case of pupil, 3 mm bilaterally reactive pupil was noted, and lens appearing to be normal as such from the initial examination part, sir. And anterior chamber as such from the examination, no hypopen were noted, but further evaluation was needed for that part also, sir. And we gave wall irrigation including face and eye wash was given, and later on we also for the part we also give some carboxymethyl eye drops are also given.
Okay.
Then then we also give a ophthalmology consultation for further management including staining, fluorescent staining, and evaluation of the further part.
Okay.
And they came and they also saw the case, sir, and from their side they did the staining, and which showed fluorescent stain uptake in both eyes, right and left eye. Fluorescent stain uptake was noted, sir.
Okay. Yeah. Okay. So I think so. This is a story of a 22-year-old male who came with a history of accidental fall of caustic soda, that is sodium hydroxide, into both the eyes. And one good thing is that they had given the wash in the site itself, right. And the patient came to the emergency services. Okay. So what is the first thing that we do other than the primary survey and the clearance of the airway, circulation, and all that, what you normally do? I think it's very important. The immediate management is something very, very important, So most of the time you'll have these particles sitting in the conjunctival cul-de-sac. So we have to mechanically remove it. Quite often it happens. So in this is probably either a powder or a solution. So it will not stick there. But quite often you see that, especially in the background of an alkali injury, especially in North India, where they use this chunna quite frequently, the children take it and squeeze it. So this will squirt out and it will go into the conjunctiva. In the upper part, it will just remain impacted and sit there, and it will keep on releasing the alkali. So that will cause almost permanent damage of the eye. So that is something very important. So you have to inspect the ocular surface completely, because we have a portion of the conjunctiva under the lids. We have to see that also. So we have to invert the lid and wash out everything. So there is something called a double immersion that we do. That is, you put some instrument underneath the lid and see like that. So even the superior fornix you can see. So that also has to be visualized. So it basically depends on the amount of the chemical nature of the agent. So sometimes it may be a strong acid or a strong alkali. So in which case, obviously the strength of the acid is important. Second thing is the duration of exposure, and then amount of surface damage it causes. Because if there is a large epithelial defect, more things can go into the anterior chamber and all that. So primarily we should give a good wash. Then we should check the pH also. There are pH papers available with which we do the pH. Unfortunately, in our emergency we don't have it. Even because of the constraints regarding the Amrita thing, we don't have it in our ophthalmic department also. But a lot of eye hospitals have that. So the normal pH is around 7.2 to 7.6, near about 7.4. So usually with a caustic soda injury, you see it as 8 or much more than that. So you keep on washing till the pH comes to normalcy. That is the end point. So it's not the amount of fluid that we use. So here we generally keep on pouring it like maybe for 15 minutes or 20 minutes. But the idea is to have pH coming to normalcy. Okay. So that pH papers are available both in the acidic range as well as the alkaline range. So that is the primary thing. That is the most important life-saving thing. No, sorry, the vision-saving thing for the patient. Okay. Then if some impacted particles are there, obviously the ophthalmologist will take it out. Then if quite often you see that there is a like one aspect is the impaction and the chemical damage that it causes. The most important thing is the limbal stem cell injury that is caused by the agent. So as you know, in the cornea and the conjunctiva, at the junction of cornea and conjunctiva, there is something called limbal stem cells which are present. So these are basically in the deeper layers of the limbus. So that is protected by melanocytes, that your God has made it like that. Just like any other stem cells, it is protected from the exposure to UV light and all that. So once there is a injury to that area, what happens is the stem cells are damaged. Once the stem cells are damaged, the cornea will become white in color. Because all the new cells, all the normal corneal epithelial cells are coming from the limbal stem cells. So as in epithelium, we have the corneal epithelial cell also lives for about 7 days. So every 7 days your epithelium is getting replaced. So if the limbal stem cell damage is there after that period, it will become because the limbal stem cells are not there, conjunctiva will overgrow onto the cornea, and the cornea will appear white in color. So the vision will be very significantly reduced. The patient will have counting fingers half meter or even less than that. So that is a very, very important thing. So the emergency management, I think it is mainly for the ophthalmologist, but it is to remove the noxious chemicals from the conjunctival cul-de-sac. Then quite often we see that there is some damage happening to there is something called this upregulation of the inflammatory mechanisms that happen. So that is why we give generally doxycycline, that is supposed to be a collagenase inhibitor. So doxycycline 100 milligram 2 times a day, we started immediately. Then for some reason, both acid as well as alkali injury causes a significant decrease in the ascorbate levels within the aqueous. So that in the long term can be dangerous. It is a promoter of inflammation also. So we give replenishment by giving mega doses of vitamin C. So that will be 1 gram 3 times a day or something like that. Then after the wash, you go on putting lubricant drops. Every 1 hour or every 2 hours you can put, depending on the amount of injury that you have. Then generally, if there is a epithelial damage as well as a limbal damage, we have to give steroids also. So because we want to reduce the onslaught of inflammation that is immediately caused. So we give steroids. Normally, as ophthalmologists, we tend not to use steroids when there is an epithelial defect because we are scared of infection. So this is a scenario in which you have a very high level of inflammation that is going to happen in the eye. So we give steroids, something like 6 times or even 1 hourly if it is a large injury. So in spite of having a total epithelial defect, we'll give steroids. That is given for the first 1 week or so. So that will reduce the amount of the inflammatory cells, the macrophages and the other antigen-bearing cells coming into the circulation and releasing further cytokines. So we can actually prevent the onslaught of inflammation happening from there. Or if the inflammation goes unchecked, it will cause something called a sterile corneal melt. So the cornea will just melt away. Corneal collagenolisis will happen, and the corneal thickness goes on decreasing, and within a few weeks you can have a corneal perforation. So that's why we give steroids, mainly topical steroids. Okay, and it's very important that you have a good epithelial cover during the first 1 week. If the epithelium is not healing, we do something called an amniotic membrane transplantation. It is basically taken from the amnion of the placental sac. So it has an advantage that it is a very good basement membrane. It does not express HLA antigens, so immunogenicity is not there. So you can put this on the surface. You can either suture it or you can put fibrin glue on the surface. So this will help in epithelialization. So even if the corneal epithelium is totally damaged, the conjunctiva can come and cover the area. So at least some amount of healing is happening. If the surface is remaining open and the inflammatory process is going on, this will cause definitely a corneal melt and perforation and loss of eye. So that should be prevented at any cost. Okay. So anything specific that you want to ask or discuss?
Isn't it not for IV steroids when on
IV steroids, yeah. But see, if you look at the eye, if you put something on the surface, the local action is much better than giving IV steroids. We can give as a aid, we can give. That is true. But I think if you're putting it directly on the surface every 1 hour, that is the more drug will reach the surface where it matters. So in the emergency management, we have to give steroids, doxycycline, vitamin C. Then quite often there will be some amount of anti-uveitis or inflammation. For that, the patient will have a lot of pain and photophobia. So you can use cycloplegic agents. Then maybe antibiotics, don't put it very vigorously, just put it 4 times a day as a prophylactic dose you can use. Some good fluoroquinolone, we can use it. Then it basically depends on whether it is how the situation is progressing within 24 to 48 hours. See, here we see quite often we see mild injuries, especially this nano lab or biochemistry lab and all. Sometimes spills happen and people come. Most of the time it is very small and innocuous. So there is a classification for the chemical injury. I don't think I'll go into the details because it may not be required for you. But the older classification was stressing too much on the corneal involvement or the corneal epithelial defect. But now we have come to understand that it is mainly the limbal stem cells and the conjunctival cells that is more important. So there is a newer classification which has come up in the 2001, Dr. Dua's classification. Though that gives a percentile of how much of cornea is involved, how much of conjunctiva is involved. So if the limbal stem cell deficiency, like if you have just 1/3 of limbal stem cells which are normal, usually the eye is salvageable if you do the other treatment properly. If it is 100% injury, most of the time it is non-salvageable. It will go. Whatever you do in the long term, it is very, very difficult to do it, to salvage that. Quite often, like in this Roper Hall classification and all that, I think they were the grade 4 is, even if you have a half, only 6 clockers of limbal stem cell deficiency, they used to put it as grade 4. So that may not be very accurate actually. If you have good limbal stem cells, even if it is even 3 or 4 clockers, that's enough. If you take care of the other parts of the eye properly in the initial period. Okay. So the chemical injury is a big problem for the eye. I think it's not very common in our part because one reason in Kerala is not very industrialized. Second thing is this lime usage, chunna usage is very less in our part now. So for these two reasons, I think it is very less. But if you go to north, I think it's very, very common.
The role of corneal transplantation.
Corneal transplantation can be done, but the thing is, quite often it's the limbal stem cell deficiency that is the problem. So you have to have the limbal stem cells working properly, then only we can think of a corneal transplant. So limbal stem cell, if it is there is a established limbal stem cell deficiency, we can take it from the other eye and use it. So that is a autologous transplant. There is you can take up to 6 clockers you can safely take from the other eye. Now we have in the last maybe 15 or 20 years, there is a procedure which has come up called simple limbal epithelial transplantation. You just need to take 1 clocker of the limbal tissue, split it into multiple pieces and put it on the cornea in multiple areas, put it on a basement membrane of amniotic membrane, attach it with the glue and put a bandage contact lens over it. Usually, quite often it gets cured after that. So previously, when you had a total limbal stem cell deficiency, we used to take it from the other eye, but we used to culture it outside. Like we used to expand the cells by using growth factors and all that, which will take about 4 to 6 weeks. And then you transplant that expanded limbal stem cells grown on the amniotic membrane onto the surface. So that was done. That is called cultivated limbal epithelial transplantation. But nowadays, the simple limbal epithelial transplant has come. In fact, it has come from L.V. Prasad Eye Institute in Hyderabad. And that is taken over, everywhere in the world, people are using it. So that is a major achievement. So this business of culturing it has gone out. So that is to the actually some of this Reliance and all people had invested in this and all that, but now that has gone off because people are not utilizing it. Okay, so quite often you are able to reconstruct the ocular surface pretty decently by doing a limbal stem cell transplant. Still, if you have a corneal scar, you can do a corneal transplant. But if you just do a transplant, it will get covered by conjunctiva within no time. Within 1 month, it will go. Okay. The unfortunate situation happens when you have a bilateral limbal stem cell deficiency. Then it's a problem. Then you have to go for an allo transplant from your kind of related donor and all that. But that also there will be rejection against it. Even if you give triple immunosuppressive therapy, there will be rejection. So it is difficult to handle it.
Prognosis of vision, sir. Whether the person able to see.
Yeah, actually, yeah. See, in the earlier grades, I think the vision will come back to 6/6. If you manage the immediate post-operative period. When I'm saying immediate post-operative period, first 1 week plus almost up to 6 weeks. Once you get the epithelium to heal properly and the limbus to form, the surface to reconstruct properly, then you'll have good vision in the long term. So I think nowadays it is easily possible. Okay, if it's a total limbal stem cell deficiency, it's a different scenario. It is very difficult to handle it.
Role of acid and alkali injuries.
Yeah, acid injury, like some of these chemical agents, this nitric acid and the sulfuric acid, these are the two main culprits. Other acids are slightly weaker. One advantage of acid injury is that it will form a coagulum and prevent the further acid from going inside. But alkali causes saponification of the cell membranes and it will not form a coagulum. So this will keep on going deep into the surface. Like all the ocular surfaces can be involved. Conjunctiva, it will cause necrosis, cornea epithelial defect, then stromal lysis, then endothelium, it will cause damage which can result in permanent corneal edema. Into the anterior chamber it can cause anterior chamber inflammation, uveitis, posterior synecdoche and all that. Then because of the chemical going into the anterior chamber again, there can be cataract formation. Even into the retina it can cause some ischemia and some chemical damage. So, but mainly it is confined to the anterior segment. But in acid, the penetration of the drug, the agent is much more compared to the alkali, the agent penetration is more compared to that of an acid. So both are dangerous. Among the alkalis, sodium hydroxide is notorious. Hydrofluoric acid and sodium hydroxide is most notorious. In the acids, I think nitric acid as well as sulfuric acid will rank as first.
So when you're giving wash, actually, which one is preferred? Distilled water or like saline?
Distilled water or saline. I don't think it makes a difference.
Both.
Both are fine. Basically, your idea is to wash off whatever residue is there and get the pH to normalcy. Okay.
Thank you, sir.
Thank you.